Okay, perfect. Thanks for joining us today, everybody. This is our uh, inaugural echo for maternal fetal medicine in South Carolina. We've done this separately from MUSC for the past year, and we took a little bit of a break over the fall and now joining forces to make it a little bit better and to try to increase the permeation of the echo across the state and get more people involved. So thanks for the starting of this. And we're going to go through what we'll try to do are the didactic sessions, basically to make sure that statewide we are at least following the guides of best practice or evidence-based practice for management situations in obstetrics and gynecology. And our first topic that we're going to work through over the next few sessions has to do with diabetes in pregnancy. One of the areas that we have a lot of questions with is how to start insulin, when to start insulin, and are there any other options to insulin when patients are having blood sugar control issues during their pregnancy. This is just a slide. Everybody realizes this and has seen this probably going through training anyway, and that is that the blood glucose levels, as they rise, the pancreatic release of insulin rises in conjunction with that to bring those sugars down. It's a very dynamic process, and people who are healthy and have normally functioning pancreases and normal sensitivity to insulin have this mirror effect. So it's meant to bring those blood sugars down when the patient has an increased blood glucose in response to ingestion of foods. Important to understand that when we're looking at the use of synthetic insulin or insulin that we give the patients subcutaneously. It's not the same as the endogenous insulin that's produced in response to glucose. We're trying to mimic that as best we can. And while we're a lot better than we used to be, we're still not great. The drugs that we use the most often, we've really gone to the rapid acting Humalog, Novolog, Apidra types of insulin over the regular insulin in recent years because it works very quickly. So I'm going to use Humalog as a general term as we go through these, but you know that it's the law of rapidly acting. The nice thing about these medicines is you can take them immediately when you eat, and it works pretty quickly to start having an effect for that ingestion of food. The onset is 10 to 30 minutes for the log insulins. It lasts for 30 minutes to 3 hours, up to 5 hours. Most of the peak is within that first hour of use. With the regular, which some people still use, and I still use it on occasion, and I'll tell you why in a few minutes, it works more slowly. So what we tell patients when we're on regular insulin is to take the regular and eat within 30 minutes of the injection. The onset of action is about 30 minutes to an hour, different for different people. The peak effect is 2 to 5 hours, but it can last at some degree up to 12 hours. Then the intermediate acting, the NPH, what we use in obstetrics a lot, is a longer acting insulin. It peaks more around 8 hours. The onset of action is about 2 hours, and it lasts for up to 24 hours in the patient. Now, the Lantus and Levemir are the brand names of the long basal doses of insulin, newer insulin. And there's just not been a lot of use in pregnancy with these medications. They're given, and they basically have no peak. They are like the basal effect of the pancreas giving insulin all the time, lasting up to 24 hours. The two problems in pregnancy with these medicines. One is they're expensive, very expensive. And number two is that the breakdown of these medicines is extremely variable depending on the particular patient. So one may last up to 36 plus hours in one patient when it may last less than 20 hours in another. And again, there's no peak, so it's really hard to adjust these insulins in response to the spikes associated with ingestion. So who do we start on insulin? And on the slide, I've got type 2 diabetes, but I'll talk first about class A diabetes or gestational diabetes. So patients with gestational diabetes will sometimes need insulin. About 15% of the patients, if they fail dietary therapy, will need insulin. And in those patients, the way I personally decide to start them on insulin is if they have over 15 to 20% of their blood sugars that are out of range. With type 2 diabetics, a little bit different. If they're on 2 oral medications or more when they come in pregnant, I suggest that that patient start insulin therapy. It's just a lot easier to control their blood sugars, and you can ratchet up and down the dose more easily. The oral agents just are more erratic in their absorption and effect. If they have one medication that they're using, let's say metformin, but their A1C is abnormal, over 5.5 to 6, I suggest that those patients start insulin as well. And all type 2 diabetics, as a general rule, will need insulin before the pregnancy is over. It's not always, but almost always, those patients will require insulin at some point. So these are the reasons that I choose regular on occasion. If I have self-pay patients that are really having a hard time affording to pay for insulin, I will use the old NPH insulin and regular insulin because it's cheap in comparison to all the others. The Novolog, the Humalog, the Apidra, they are pretty expensive. Now, insurance companies, they'll drive you crazy because one month they may approve Humalog for a patient and then deny it the next month and say we've switched to Novolog. So you have to understand that insurers will dictate many times which of the insulins that you will use. And they actually have gotten it. They understand that the log insulin is better for the patient because the studies show clearly that using the log derivatives actually improve the A1C by over 1% over the regular insulin. So it really does make a difference to use the log derivatives if they have insurance and if they'll pay for it. A couple of warnings. I do not like for you to use the insulin mixes, the 70-30, the 60-40, the 50-50, because every patient is different, and that's why we like the log and the NPH, because we can tailor our treatment based on what the patient needs are. A lot more hypoglycemia and hyperglycemia using those insulin mixes. And I already mentioned the long-lasting, the Lantus and the Levemir, the basal. Those insulins are a lot less predictive in patients that are pregnant. If a patient comes in and is on one of those long-lasting insulins and well controlled, I will frequently leave them on those medications for a period of time. But if we start having difficulty with blood sugar control, I'll take them off and switch them over to the NPH. Next slide. So to calculate the dose, people have different numbers that they use, but I like the 0.7 per kg for my total insulin dose. Then I divide it by 3, and then I give 2/3 in the morning, 1/3 at night, with the morning dose giving 2/3 of the intermediate dose and 1/3 short acting. And in the evening, I give half intermediate and half short acting. I prefer to give the intermediate dose, the NPH, at bedtime. That helps cover the evening snacks in the middle of the night. It just seems to work better. It is another additional injection, but I think it is helpful to their blood sugar control. Another way to do this, so if you, let's say you have a very obese patient, you do the weight-based regimen, it may be an astronomical amount of insulin to start a patient on. In those cases, I use the old guideline of 20 of NPH and 10 of log in the morning, 10 of NPH, 10 of log with dinner. So you can tailor it. Sometimes you can be worried about starting a patient, an insulin naive patient, on very heavy doses. So that's another way to do patients who have not been on insulin prior to this. Next slide. So this is just an example of how to do it. I think everybody can do math probably better than me, but just to calculate the insulin, something that I see a lot here, and we do it to tailor a patient's blood sugar control if needed, is to add rapid acting insulin with the lunchtime meal if needed. It just depends on how their blood sugars respond. Next slide. And from a patient education standpoint, just some simple things to make sure that those patients who've not been well controlled when they go on insulin, it's going to make them tired. They don't like being well controlled. It makes them feel badly. It takes 2 to 3 weeks for their bodies to get used to it. Talk to them about signs and symptoms of hypoglycemia and how to correct it. Peanut butter, crackers, milk, cheese, crackers. Don't do something that one of our nurses did a few weeks ago here when they gave a glass of orange juice with 2 teaspoons of sugar. Bad choice. Yeah, that happened as an inpatient. So juices just have too much simple sugar and overcorrect the blood sugar. Another good idea is to have these patients have a glucagon injectable kit at home in case they get so low they can't take anything orally. I have these patients call us every 3 days initially to make sure their sugars are okay, and I see them back within a week. And just a simple thing I tell the residents that they don't realize, because a lot of patients don't know which is rapid or intermediate acting. Insulin is the rapid acting, and the cloudy insulin is the intermediate acting. It's just a simple thing that you can remember to talk at the patient's level to make sure everybody is on the same page. And I make sure that we give them written instructions on how to use the insulin and what doses they're supposed to be on, so there's no confusion. And I think that's it.
Thank you, Dr. Campbell. And this is just a note for upcoming didactic topics. We will meet again on December 18th for pre-gestational diabetes, PC ratio, or 24-hour urine. And also to note other telementoring programs in our state along with this Pregnancy Wellness Echo is we have a Project Echo opioid use disorders, and there is also a Southeast Viral Hepatitis Interactive Case Conference. So those are to note if anyone is interested to join those. I can give additional information